Next slide. Our funding for the Maine Lung Cancer Coalition is the Bristol Myers Squibb Foundation, the Maine Cancer Foundation, and the Maine Economic Improvement Fund. Today, we are so happy to have Dr. Gary Hochheiser here with us, and he is going to speak about lung cancer screening and following up on abnormal low-dose CT scans with us today. So just a few webinar logistics for Zoom. The audio lines for non-presenters are currently muted, so please use the chat box for any questions or comments that you have during the presentation. Dr. Hochheiser has mentioned also that he will be happy to answer questions during the presentation, so feel free to put them up in the chat box, and Lizzie will be monitoring the chat box during this presentation, and we'll be reading those to the audience. If you are requesting CME for this webinar and you did not sign up to Zoom through a direct link, or you're watching as part of a group, please email mlcc@mainequalitycounts.org either during the presentation or after the webinar so we can track your participation and make sure you get the follow-up surveys for everyone that participated for CMEs. This is just a slide to introduce you to many of the staff here at Quality Counts, and we are working in Maine to truly improve. Our goal is to improve the health of everyone in Maine. You can connect with us in multiple ways. You can see the different social media sites at the bottom, and our email is mainequalitycounts.org to get on our email list. So today for speaker disclosure and CME certificates, for CME disclosure, the speaker today does not have any relevant financial relationships with the manufacturers of any commercial products and or provider of commercial services discussed in this CME activity. Via email. Typically, we try to get that out in the next couple of days. Please complete the survey via the SurveyMonkey within 1 week, and the CME certificate will be mailed then within 1 month of completion of the survey. So that's the housekeeping, and now on to the real reason you're all here, the presentation. So for today's presenter, again, we are so happy to have Dr. Hochheiser here. He is the surgical oncology, thoracic, and cardiac surgery and works for Maine Medical Partners. He is the director of thoracic surgery and thoracic oncology and medical director for the lung cancer screening program at Maine Medical Center. And he specializes in minimally invasive procedures in the treatment of thoracic diseases, including both benign and malignant diseases of the lung, esophagus, and pleura, along with the surgical treatment of lung and esophageal cancer, as well as lung-sparing cancer surgery. He's a past instructor of minimally thoracic procedures. He has an interest in both benign and malignant diseases of the esophagus, including reflux, hiatal hernia, and esophageal motility disorders. So again, we are so happy to have him, and I'm going to turn this platform over to him. So.
Great, thank you. So as Jessica said, I'm Dr. Hochheiser. I'm the director of the thoracic surgery program here at Maine Medical Center and medical director of our lung cancer screening program. And I've been involved with lung cancer screening for probably the last 7 or 8 years, at building a program at a prior institution before coming here and helping to build ours here. So I have a little experience, but I think one of the things that is not often talked about with lung cancer screening is we get all involved with building a program and how to get people scans and the shared decision making and all of that part. And then really I think the meat of the program is what do you do with what you find? And you're probably aware that CMS had some pretty tough things to say about lung cancer screening before they said they were going to reimburse for it. And that had to do with the fact that they were concerned about the cost and the risk to patients for following up on these findings and the possibility that people may get more than they actually need. So why don't you go ahead on the next slide. So I'll talk a little bit about lung cancer screening in general. I'll briefly review the NLST because that's really how we got here. And there's some differences between how we handle things now and how they handle things in the trial. So I would like to kind of point those out. And then we'll go dive deep into the ACR guidelines. And then a little bit about what to do with those findings. So again, the aim of any screening program is early diagnosis And we certainly are falling short on lung cancer with early diagnosis because about 85% of our cases, sorry, our lights just went out. We have a automatic light system here. So 85% of our cases are diagnosed at advanced stage, which decreases the ability for us to cure those patients. And so we'd like to get early diagnosis so we can get them treatment in early stages to help cure. So next slide. So the National Lung Cancer Screening Trial, I hope this is review for most, but it was a big multi-institutional study, randomized trial of the low-dose CAT scans versus a chest x-ray, and it was originally reported in the New England Journal in 2011. Huge number of patients, 53,000 patients, and they determined a high-risk group, and I didn't put the quotes there, but so this was a group that they had decided on to ensure that they would have a good number of people who had the disease within their screening group. So they picked ages 55 to 74, the 30-pack-year history, and quit within the last 15 years. And all of that's just the screening guidelines now. So they did 3 annual screens because they had to end the study at some point, and then followed up on the findings of those. And just to put all of this in perspective, this is essentially a government-run trial. It cost $200 million to do this study. So we're not likely to get a study of this size or this quality ever again. Next slide. So what did they find? They found a relative mortality reduction of 20% in the screen groups, and an overall 6 or almost 7% reduction in all-cause mortality. So this is the first trial that's ever shown a screen for lung cancer to have a significant reduction in mortality in a randomized trial. The problem with this is that they found that almost 25% of the positives or of the scans were positive. That's a huge number when you're talking about screening. And they used a nodule of 4 millimeters or larger as being a positive scan. The problem being that 95% of those were false positives, so not cancer. And somehow we've got to figure out a system to be sure that we're not doing invasive procedures and things on these false positive patients. They did find cancer in 1% of the population. Next slide. So before all of this was implemented in sort of the general population, once CMS had said, okay, we're going to pay for this, and here are some of the guidelines, and the U.S. Preventative Task Services came out with their recommendations. We needed a way to categorize the findings, and who better to kind of put that together than the American College of Radiology. And they had done this for breast cancer screening previously. They have a BI-RAD system for mammograms. So they sort of adapted the same methodology to produce the LungRAD system for lung screening. And it's the lung imaging, reporting, and data system. And it's very similar to Fleischner, but this was specifically designed for the lung cancer screening population. And so they developed categories based on the size of the nodules, and they took into account both or all 3, solid, part solid, and non-solid, otherwise known as our ground glass nodules or ground glass opacities. And then there was the whole idea of a new finding versus an initial finding or a baseline finding on the initial imaging. So they took all of that into account to build the system. Next slide. So one of the things that they did that was different than the NLST was they changed the threshold of what they considered to be positive. And it's not a huge change, but they moved the nodule size up from 4 millimeters to 6 millimeters. And the idea of this was to limit the number of false positives so that we weren't chasing our tails working up tiny little nodules that were never going to become anything. They also set a minimal size for a ground glass opacity as 20 millimeters. And I think their thinking behind that is really based on the fact that the type of malignancy associated with those ground glass opacities is much less aggressive than our standard lung cancers. And so they didn't want to overtreat things that might not change patients' prognosis. So what they did was decrease the rate of false positives significantly. However, the trade-off whenever you do that is you decrease the sensitivity of your screening test. The good news is that with even the small nodules, they are going to be followed. They're not going to be just ignored. So even though we might not catch them on the first scan, there is a system to follow up on that to ensure that they don't fall through the cracks, so to speak. Next slide. So again, the major concern for CMS was all of the false positives. And the reason behind that is that if we start doing procedures on people to biopsy or operate on these people, that we're going to add risk. And again, the majority of these are not going to be cancer. And so we have to figure out a way to limit the number of procedures and risks that we're adding to patients. And so CMS was pretty tough when they did their review of the data and really kind of put that forward in their recommendations, that we be careful about how we handle the findings. However, nobody has prescribed the way to deal with it, and one of the goals of the ACR was to help figure that out. So again, the goal is to limit the number of procedures for the false positives. And then there's this issue of overdiagnosis. And that's the finding of a slow-growing malignancy that is not going to affect the prognosis of the patient. And that's a difficult one to manage, because unless you have interval imaging, it's difficult to know if something is slow-growing or not. And then we certainly don't want to not treat a cancer that might be potentially significant. So that's a difficult one, but that's one of the reasons for all of the surveillance that we're doing. Next slide. So before we get into the ACR and in depth about each category, what are our tools to follow up on these nodules? And really the baseline for most of them is imaging, whether that be interval CAT scans down the road, looking for growth or change in those nodules that were identified, and then PET CT scans. But again, all of these things have their downsides. So if we're going to follow a nodule and we're going to have an interval of follow-up, if it's a really aggressive, fast-growing lesion, we may miss our opportunity to treat in a lower stage. And with PET CT imaging, there are lots of things that we find on PET CT scans that are not related to the nodule itself, and may lead us down a road of doing other workup and adding risk for that. So incidental findings are a big issue with PET CT scans. Also, the resolution of the scan doesn't start until you get to 8 millimeters. So there's many of these nodules that we're finding that aren't even amenable to being imaged with a PET scan. So next slide. And then getting more sort of invasive and aggressive. Certainly we have CAT scan guided needle biopsies, which are fairly safe, but have, again, a side effect risk profile, including pneumothorax, bleed, so all the false negatives from biopsies, as well as the added radiation of another scan. We can also do biopsies with bronchoscopy. There's some to reach it with a bronchoscopy, although we do have some new image-guided systems available that can help us sort of drive the scope through the nodule and help with the sensitivity of those biopsies. And again, anytime we do a procedure in the airway, you require some kind of sedation or anesthesia, and there's and then sort of the biggest or most aggressive way would be a surgical biopsy, where we actually do an operation to remove the area of the lung that the nodule is in for definitive diagnosis. Again, and that carries with it even more metastatic and perioperative risks, although it's also a chance to perform a diagnostic and a therapeutic procedure in one setting. So in the appropriate patients, that might be the way to go. Next slide. So this is the ACR guideline, and I should have put a link up there to it, but you can go to the ACR website and find this. This is Lung-RADS version 1. They have not come out with a version 1.1 or 2.0 yet, and I'm sorry, it looks a little blurry to me. I'm not sure if it does to you, but we'll go through each of the categories, and this is sort of just to show that it's not a simple system. It's fairly complex, but it takes into account the sort of description of what the category means, the category number, the findings, what puts you in that category, as well as a recommendation for management. And I say that very carefully, a recommendation for management, and we'll get into that a little bit later. The probability that that nodule is malignant, at least in the group that they studied, and then the prevalence of that finding in the lung cancer screening population. So what's the likelihood that you're going to find a category 1 or a category 2? Next slide. So let's go into the categories a little bit deeper. Category 1 is sort of the most simple. We didn't see anything. Or what we did see has something very specific about it that lets us know that it's benign. Essentially, there's only a couple of things that you can hang your hat on for benign nodules. One is no evidence of growth over a long period of time, which we don't have until we get into rescreening or rescanning people. And then the presence of these specific types of calcifications. If the nodule is completely calcified, if there's central calcification, the so-called popcorn calcifications or concentric rings, and then the fat-containing nodules like hamartomas. And so, this is standard in the radiology literature about the chances of these being benign. I wish that light would stay on. So the probability of malignancy in this group is less than 1%. Sorry about our light show over here. And the recommendation is that people just continue with their annual low-dose CT scan. And the prevalence, this is most of your patients are going to have a category 1 or a category 2. So next slide, we'll get on to category 2. And category 2 is nodules that have either a benign appearance or expected to have benign behavior. And so these are solid nodules less than 6 millimeters, or if you had a previous scan and are getting a new scan, say a 6-month or a 12-month new screening scan, it would be a new nodule that showed up in that interval that is less than 4 millimeters, because that's generally considered growth if it wasn't there before and it's there now. Part solid lesions less than 6 millimeters. So if you have a lesion that's ground glass but has a part of it is solid on the imaging, that solid portion is less than 6 millimeters. And then the non-solid lesions less than 20 millimeters, or a 20 millimeter non-solid lesion that is either stable or quote-unquote slow growth. They do not define slow growth, but essentially these are the ground glass or lipidic growth adenocarcinomas that we see. And again, if they are stable, there may not be an indication to do anything except follow them for another year. And then as we get along in the categories, if you have a nodule that fits into category 3 or 4, and you do an interval scan to follow that nodule, and it's either stable or decreases in size, those drop down to a category 2. That's a subtlety that's sort of on the page 2 of the ACR recommendations, and it is slipped in there in the category 3 and 4 recommendation. So the recommendation for category 2s is like category 1, which is continued annual screening. The probability of malignancy and the prevalence are the same as category 1, and category 1 and 2 are sort of lumped together as sort of negative studies. Next slide. So category 3, so these are, quote, probably benign. Again, these are nodules that are a little bit larger, so if they're solid, they're 6 millimeters to 8 millimeters. If they're new, they're above 4 but less than 6. And again, this is all spelled out in the ACR table there. Part solid nodules that are larger than 6 millimeters with a solid component that's less than 6 millimeters, or a new nodule or part solid nodule that's less than 6 millimeters. So you can imagine the radiologist sitting and reading the scans, and they've got this chart by their side, and they'll say, measuring nodules and saying, where does that fit? That's exactly what they're doing. They do keep these charts right by their side when they're reading their imaging. The non-solid nodules, that's supposed to read 20 millimeters, my apology. 20 millimeters or larger, or growing. And then the recommendation for these is, okay, these are probably benign, but they're a little bit larger and we're a little bit more concerned about them, so we're going to do a shorter interval scan, and that's a 6-month scan. The probability of malignancy is 1 to 2%, so a little bit higher than our categories in 1s and 2s, but still very, very low. So you can imagine we're doing a lot of imaging to find that 1 to 2%. And this accounts for about 5% of the patients who are scanned. Next slide. So now we get into what I consider to be the meat of lung cancer screening, and these are the suspicious nodules. So category 4, there's 3 categories for 4, for A, B, and X, which we'll go through. And their description of this category is that findings that for which additional diagnostic testing and or tissue sampling is recommended. So diagnostic testing can mean either a CAT scan, a PET scan, or some kind of biopsy of the lesion. And again, as you'll see, these nodules are now amenable to biopsy. They're within the size range where we start to think that either we can get a PET scan or we can get a biopsy. So 4A is the solid nodules, 8 to 15, or less than 8 if you have shown growth. So if you have a prior scan where the nodule was 4 and now it's 7, that's a growing nodule and it becomes a higher level. Or if you have a prior negative scan and you have a new 6 to 8 millimeter nodule that shows up. And again, there's different or increased size for the part solid nodules, where the solid component increases in size, or if there's a new part solid nodule with the solid component that's been growing. The other thing that's thrown in here is this endobronchial nodule. So if there's a nodule seen within the airway on the CT scan, that's thrown into 4A. And the point of all of this is that these are things that you can't necessarily just sit on and do 6 or 12-month interval scanning, because the risk of malignancy is higher, which we'll show in just a second. The recommendation here is a 3-month interval CT, and with Fleischner, 3-month is the shortest interval. So if you are going to follow a nodule that is suspicious, 3 months is sort of the shortest interval that's recommended. If this nodule has an 8 millimeter or larger solid component, so if it's either a solid nodule or part solid with an 8 millimeter solid component, then PET CT scan can be used. And you can see how as we get into category 4, things become a little bit more muddy about where to go. Do we do a PET? Do we do a 3-month follow-up? Do we do a biopsy? And we'll get more into how to deal with that in a few minutes. Next slide. So 4As have a probability of malignancy from 5 to 15%. So now we're getting into you're definitely going to have some patients in here who have lung cancer, and what we don't want to do is miss our window of opportunity of the early diagnosis and early treatment. Again, this is only 2% of the patients that are scanned. Next slide. So 4B is also suspicious, but now we're into a centimeter and a half or larger, or if they're new or growing and 8 millimeters or larger. So these are things that are either growing definitively or are big enough that we need to worry about them. And then part solid lesions where the solid component is 8 millimeters or greater, or they're 4 millimeters and growing. And then there's this category 4X, which is the category 3 or 4 nodules that have additional features or imaging findings that increase the suspicion of malignancy. And this may be hilar or mediastinal lymph nodes, chest wall invasion, something like that, that increases the risk that it's truly a malignancy. Remember, this is nodules that may be 15 millimeters or larger, but that could be a 7-centimeter mass that was picked up on initial imaging. So it's not just thinking about these as tiny nodules. So the recommendations at this point are a CT scan of the chest with contrast. I'm not sure why without is there. I apologize. And then either a full diagnostic chest CT, a PET scan, or tissue sampling. And here's where we really get into situations where we have to decide what's the right thing for that patient. So the probability of malignancy is now greater than 15%. So this is the category where we really need to be more aggressive with them. And the prevalence of scanned patients is 2%. And so you can see the ACR kind of laid out the system to increasing levels of suspicion based on data of the probability that that nodule is a malignant nodule, and recommendations to go along with those. I sort of consider the 1, 2s, and 3s as sort of protocol type categories with sort of protocol type follow-up. But the category 4s are something that falls into a different clinical scenario. And when you start to think about what the follow-up for stage or category 4 patients is, you really have to think about more of a bigger picture, including the patient, their comorbidities, and what is right for the lesion or the imaging that's been presented. And again, we'll go through that a little bit more. Next slide. The other thing they added were additional findings, and it turns out that this may be part of the reason that the mortality benefit from screening was so great. But there's an S category, which is considered for significant other findings. We see a lot of enlarged aortas, so aortic aneurysms, and things like that, mediastinal masses, and sometimes even some upper abdominal findings that are significant. So those are reported as a separate category, as an S category, and followed up based on those findings. And then the C category is just there for patients who have had a prior lung cancer and have been through treatment and are now back into the screening system. And generally, we do surveillance for 5 years on our lung cancer patients and then put them back into the screening program if they fit the other criteria. Personally, I think that a prior history of lung cancer puts you at a higher risk than the actual screening guidelines. Unfortunately, because the screening guidelines came directly from the NLST, we don't have a place for these people, but I have plenty of patients who don't fit screening guidelines who have had lung cancer, and we're not allowed to screen them without them paying out of pocket. So hopefully down the road we'll get more information about risk and patient risk and who we should be screening and who we should not be screening. Next slide. So what do we do with the category 4s? These are the important ones, and the reason they're important is obviously because they have the highest risk of being malignancy. But we have to remember that most of them are still going to be benign, and so we have to try to limit the things we do to these patients to find out either malignancy or benign, and try to prevent the risk to the patient. So what are our options? Again, repeat imaging with an interval of usually 3 months. A PET CT if it's 8 millimeter or larger, or a biopsy. And these are not all mutually exclusive. Sometimes we'll get a PET CT. If the PET is negative and the lesion does not light up, then we go with an interval scan, or sometimes we do that with biopsies. But again, you can see how the decision making here becomes more than just a protocol. If this, then do that. There's different options for different patients. And then within category 4, you can have anything from an 8 millimeter nodule all the way up to a 7 centimeter mass or more. You can have hilar or mediastinal adenopathy. You can have other findings that are concerning. And so repeating an interval of 3 months doesn't necessarily make sense. And so here's where clinical decision making comes into play. And as you'll see, I have a sort of my own view about how we should be handling these. We also have to take care of patient factors, or take into account the patient factors. Are these patients who are candidates for surgery or radiation? What are their comorbidities? What's their functional status? And can they go through treatment? Hopefully, on the front end, we've done a pretty good review of that, and only are screening patients who we think could tolerate treatment if lung cancer was found. So, but again, as we're making these decisions about what we're going to do for each patient, there clearly is patient factors that have to be taken into account. Next slide. So this is where my plug comes in for evaluating these nodules as a team in a multidisciplinary fashion. And the reason for that is that there are different ways and different specialties that handle nodules and handle patients with lung cancer and lung nodules. And not always do we have the same views and the same ways of proceeding with evaluation and workup. And again, I think the goal with screening is to limit the harm and to make sure that we're not doing too much. And I think the best way to do that, and this is similar to how to deal with lung cancer, but is in a multidisciplinary fashion. And so we use nodule experts from all the specialties that handle them, including our radiologists who are reading the scans. And these are screening specific radiologists, as well as people with interventional expertise, because these are the people who are going to be able to tell us, is this nodule amenable to a percutaneous biopsy? What the options are from a radiology standpoint. On the other hand, our pulmonologists, who also deal with a lot of nodules, particularly benign nodules, and follow-up for those, are very experienced in this, as well as experienced with other biopsy techniques, including bronchoscopy and endobronchial ultrasound. And so they're going to be able to provide that perspective of when those procedures were going to be helpful, and what the yield might be, as well as the risk. And then obviously the thoracic surgeons, particularly thoracic surgeons with minimally invasive training. Hopefully we're diagnosing these things at an early stage and going to be able to treat them minimally invasively. Particularly when we're talking about doing biopsies of unknown nodules, we want to be able to limit the risk to the patient, which are minimally invasive techniques have helped us do. Next slide. So the idea is that the multidisciplinary team would do a nodule review, and we would try to obtain as much patient data as possible. And this often has to do with contacting the primary care physician for that patient and getting, problem lists and medical histories and surgical histories, so that we can figure out where these people are sitting and whether or not they would be candidates for any of the things that we might recommend. And then we have a team discussion where we look at the nodule itself, we take into account all the rest of the information, and come up with a decision on what to do for that patient, whether we follow this, repeat with further imaging, or tissue sampling, and what procedure we're going to use if we're going to do tissue sampling. The other thing that this does is it allows us to help direct a referral for that patient to the appropriate physician. So if we're going to be doing a percutaneous biopsy, then we can get that set up and the referral in for radiology, as the radiologist is part of our discussion and evaluation. The patient's already been reviewed. Next slide. So what does this help us do? I think the number one thing is it kind of helps bring everybody online into how to manage nodules sort of on a similar fashion. I think, we all have our expertise, but we also all have our biases. And I think that we can mitigate some of that if we can have a discussion around the pros and cons of each option, and come to a group decision about that. I think that's true in any multidisciplinary evaluation. This way we also get expertise in all the aspects of nodule evaluation and all of the biopsy techniques. And then again, it allows for us to have an efficient navigation of care, so that the next steps for the patient can be followed up quickly, and there's already a knowledge of that patient before the patient gets on to their next steps in their care. Next slide. So one of the things that we've done here at Maine Med is we do have a nodule group, or a nodule clinic, for lack of a better term. We aren't physically seeing the patients in that nodule clinic, but our navigators do work up these patients, get as much of the information as possible, and then we review. So these are all of the category 4 patients. And this is, again, a multi-specialty team. But what we've added to it is the ability for people to present cases from anywhere. And essentially, we do the same thing that we're doing right now, and we hook up electronically. Our radiologists can look at the images and display them on our online system. And so we've had pulmonologists come in from the outside to present cases, and obviously our radiologists. And we use this for our lung cancer screening patients, but we also use this for any nodule patients that may come up. And so it presents a multi-specialty evaluation via electronic means to essentially anybody who would, wishes to access it. And so it's through the video link. Again, we present the cases, we discuss the findings, and we present recommendations for follow-up. This way, patients don't have to travel. You have a lung nodule, primary care sends them to a pulmonologist. They may have to travel, particularly in Maine, a great distance to get to see that specialist. And this way, we can evaluate all of that stuff without having to send patients all over the place. And I think this is particularly important in Maine due to all of our rural communities. And I know that I've been working with the Maine Lung Cancer Coalition about how do we deliver screening to the rural communities in Maine that really need it. And I just think that this is one of the pieces that may help us do that in a way that keeps the patient at home, but allows them to get the expertise of a screening program. I think that's all I have. I'm certainly open to any questions, any discussion about ACR, etc. So I did such a good job that nobody has any questions. I'm not sure I can believe that. Or comments about the way you might do it in your programs, or things that you've seen work.
And just a reminder, you can use that Q&A function button on your toolbar to chat in any questions or comments for Dr. Hoheiser. I don't see any so far, but I'll let you know.
We'll give everybody a couple of minutes. That's the case. I think it is. Yeah, there's no questions today, I think. I think
we've got time. We can open it up to questions about other things.
Yeah. Is there any other questions about anything else that anyone would like to bring up? Or we all?
All right.
All right. Well, thank you so much, Dr. Hoheiser, for being here with us today. We're so happy to have you. And let's see, I think I'll have you advance the screen, the slides. So at this point, I think I'd just like to, and again, while we're wrapping up, feel free to put in any questions that you might have. Again, please join us for the next MLCC webinar. We will be looking at the insurance coverage for low-dose CT lung screenings, and we'll have Andrea Quiswell. She's the Senior Manager of Medical Outreach for the Kentucky Leads Program at the Lung Cancer Alliance. And we also have Barbara Wiggin, who will be joining us from Maine General Medical Center, and that will be July 18th from 12 to 1. Oh, here we go.
You have, yep, we have a couple, it looks like. We have one comment / question. Great presentation. What kind of challenges do you anticipate in running a virtual nodule clinic?
I think our biggest challenge is getting the word out that it's available. There are technical challenges, as you probably know. Sharing images, things like that are often difficult. And then the other thing is getting the word back and how to manage the follow-up based on the recommendations. Because again, if people are in rural communities, then at some point, if there's going to be procedures or follow-up, there's going to be some travel involved with that. So I think those are our biggest challenges. We've been doing our nodule clinic virtually for a few months now, and we don't actually physically get together as a group. We have people in 3 different areas: pulmonary, radiology, and surgery, but we're all online together. And it works pretty well. Obviously, with any technological system like that, there are glitches that can happen, and we have had some trouble on occasion getting the system to work. But I think it's relatively common in the world today to do virtual meetings, et cetera, and that's something that's relatively easy to overcome.
Yeah, and I have a sort of a follow-up. You may have addressed this a little bit already, but we have one that says, what is being done in regard to letting rural Maine know they will have less travel?
Well, hopefully we're going to, again, our virtual clinic is relatively new, and we are about to sort of open it up to the world, so to speak, or at least Maine. But a lot of that is going to be done through Maine Health, just because that's our group of partners, and Maine Health's goal is to try to get screening out to all of their communities. But I think we've been working with Neil Corson and MLCC, and this is a big priority of theirs, is to get rural screening set up, and I really think that once we can get the word out, and I think the idea would be to get, there's 4 essentially large centers in Maine that are doing lung cancer screening, and I think if there was a virtual clinic in each one of those settings, we could cover most of the state through those 4, maybe 5 programs, and get this, taken care of in that sort of way, so that people didn't have to travel.
Great.
That's great. I actually have another question too. So, like when you're sharing the screens, is there a special resolution that you have to have when you're looking at, or it's just how it comes up on the technology between all 3 of you?
Yeah, our current technology is okay, and we can see the imaging. We need to go a step further, and we're working with IT on trying to provide us with a better platform. Sometimes the radiologist will scroll through the images and it'll skip, and we'll miss all the middle stuff. One of the things that we often do is we pull up another computer with the imaging on it so that we can look through it ourselves, which with any kind of PACS system you can do that. But at least that way we have an idea of we're all looking at the same thing. But I think we could do a better job. I think the technology is out there. I think we're a little bit limited by our own hardware and a little bit by our own software. And if we really sort of put some effort into it, we probably could come up with a much better system. I mean, if my kids can stream a movie on their computer with pretty high quality, or play one of their video games, I think we can share images.
Absolutely. Yeah. Great. Excellent. So I think, is there any more questions?
I don't see any more questions coming in, but if people have them, feel free to chat those in or use the Q&A function.
All right, we'll give people a few more minutes.
Oh.
Yeah.
Do you anticipate any decline in the number of false positives?
I think there's already been one in that by using lung rads, we're not using the same criteria as NLST, and so by increasing the size that we call positive, we've already seen that. Down the road, there's a lot of data in Europe about using volumetric analysis rather than measuring the size of the lesion in a single plane, and I think that may help us lower the false positive a little bit more. I think it's a little bit more nuanced technique that's probably a little bit more accurate. So hopefully down the line, we'll get there. We have the software to do that in the United States. I'm not sure why it hasn't caught on here yet, but that's pretty common in Europe for them to use a volumetric analysis. So hopefully, yes. I mean, then what we really do want to do is to decrease the false positives so that we can, avoid imaging or intervention on those patients.
Great question.
That seems like all on the question end.
Great, and please know if you think of anything as well that, again, you can always reach us at our email, and we can always get those questions over to Dr. Hochheiser as well to answer any that might come in later. So I think at this point, I think we're all set. We would, again, invite you to join us at the next webinar, and we thank you. This is the Maine Lung Cancer Coalition website. We invite you to learn more about the Maine Lung Cancer Coalition and visit this website. And again, we're always around to answer any questions you may have about that as well. So to all of you, thank you so much for joining us today. And again, a big thank you to Dr. Hochheiser for joining us and presenting with us today. And thank you all and have a wonderful day.